Good morning. This is Dr. Saeed Al Nasser. Today we are going to talk about pediatric hip disorders. Um, the most important two topics are number one, Perthes disease, and number two, slipped capital femoral epiphysis. So we will discuss these two conditions um, with my audio explanation, and the rest of the topics can be self-reading. The first topic is leg-calvé-perthes disease, LCPD, or what we call in general Perthes disease. This is a condition that affects only the pediatric population. It is an idiopathic avascular necrosis of the femoral head in the growing child. This is a disease of males. It affects males much more commonly than females. It is usually unilateral but can sometimes be bilateral. Perthes disease is of unknown etiology, so there is no obvious and direct cause for the Perthes disease, but there are a few theories about the cause. The most important theory is the coagulopathy theory, as it was found that many children with Perthes disease have coagulopathies like factor C and S deficiencies, etc. But there are other theories regarding the cause of Perthes disease. Although there is no clear etiology, as we said earlier, but there are few risk factors for the disease. As we said, this is a disease of males predominantly. 80% of patients are males, and it affects children between 4 and 9 years of age in general. There are exceptions, but most of the patients are between 4 and 9. It affects children of low social economic status and with short stature and delayed bone age. These children are often very thin and very active and very small for age. That's why there was a few theories regarding the causes. For example, vitamin D deficiency was suggested at some stage. So patients with Perthes disease, as we said, are generally males and usually between 4 and 9. They present with either a painless limp or sometimes with pain, and the pain can be in the groin or in the thigh or in the knee. This is very, very important because many children with the hip pathology present with knee pain or thigh pain, and that can be misleading for the treating physician, especially in the emergency departments. And many cases of hip pathology have been missed in the past because the patients were complaining of knee pain. So this is very important to remember, especially in children. So as we said, these patients can present with limping or abnormal gait, and the most common gait presented is the antalgic gait, which is a gait caused by pain on the affected side. As you know, the gait cycle is compromised of two stages: the stance phase, where the foot is touching the floor, and the swing phase where the foot is not touching the floor. The antalgic gait, caused by pain in general, causes a short stance phase, regardless of the cause of the pain. So when you see an antalgic gait, you can predict that the patient has pain on the affected side, but it will not give you the diagnosis. Also, patients with Perthes disease have decreased abduction and internal rotation on physical examination, and very late signs include leg length discrepancy due to collapse of the femoral head. So to assess a child with hip, thigh or knee pain after obtaining history, we need to examine the affected area. As I said, even if the patient is complaining of knee pain, we will need to do a hip examination, checking for restriction in the range of movements, particularly abduction and internal rotation. And if the pain has been there for a long time, we check for leg length discrepancy. And after that, we will need to start investigations. The most important investigation is the X-ray. So we get an AP X-ray of the pelvis and the frog lateral pelvis view as well, looking for changes associated with Perthes disease. And the main changes are flattening, sclerosis, and fragmentation of the femoral epiphyses. And sometimes we can see subchondral fractures, or what we call the crescent sign. So this is X-rays of a patient complaining of hip pain. The top one is an AP view, anterior to posterior view, and the bottom one is what we call a frog lateral view, which gives you a lateral view of the hip joint. You can see on the X-rays that the right hip is affected. The epiphysis is smaller on size on the right side. There are some signs of irregularity in the epiphysis on the bottom X-rays, with slight flattening and a subchondral fracture of the right epiphysis. This X-ray is not clear, so we will skip it. This is a very important slide. It shows you the stages that the Perthes disease go through. All patients with Perthes disease will go through these stages. As you can see, there are 4 stages. The first stage is what we call the necrotic stage, where the ischemia starts in the femoral head. Very often there are no radiological signs at all during this stage. Usually this stage lasts for 6 months. The second stage is the fragmentation stage, which is the most important stage. And in this stage, the femoral head becomes very soft and it starts to fragment and collapse. During this stage, the femoral head is at its weakest point, so we should protect the joint, particularly by avoiding heavy activities, jumping, sports, etc. And this stage also lasts for 6 months on average. The third stage is the reossification stage, where the blood supply comes back again and a new bone formation is noted on the X-ray. And this stage lasts for 9 to 18 months. And the fourth stage, what we call the remodeling stage, is the last stage of the disease, where the bone tries to go back to its original shape, and this depends on the age. The younger the child, the more remodeling potential it has. That's why age is a very important prognostic determining factor. So patients who get the disease at a younger age, generally speaking, they have better prognosis. One important thing to note, which I mentioned earlier, This Perthes disease is caused by avascular necrosis. However, the difference between Perthes disease and the adult type avascular necrosis is that the ischemia in Perthes disease is reversible. So you get ischemia initially, but then after a few months, the perfusion is reinstated to the femoral head, and that's why you start to get a new bone formation. Otherwise, in standard avascular necrosis caused by fractures or by steroid use, etc., there is no reperfusion. So the ischemia happens and the blood supply does not come back again, so the changes are permanent. While in Perthes disease, it's different. We don't know exactly the etiology and the pathophysiology of the disease, but this is what happens. This X-ray, it says stage 1, but in fact, if you look closely, there are signs of fragmentation, so this should be considered as stage 2. X-ray on the left shows stage 2, which is the fragmentation stage, where we start to see flattening of the femoral head and fragmentation of the epiphyses. In the right-hand picture, stage 3, or the ossification phase, we start to see new bone formation between the fragments of the epiphyses, and this is the beginning of the healing. An X-ray of stage 4, the remodeling stage, where the epiphyses or the ossification has finished, and we can see all of the epiphyses now, and then from now on the remodeling starts, trying to go back to the original shape depending on the age of the patient. The top left X-ray shows a lucent line in the epiphyses. This is what we call a subchondral fracture, or the crescent sign, which is characteristic for Perthes disease and usually happens during stage 1 of the disease, and very often this is the only sign of stage 1. The picture on the top right shows some fragmentation. The picture on the bottom left shows collapse of the femoral head and flattening, with some cyst formation in the metaphyseal area. And you can also see that the epiphysis is slightly protruding laterally beyond the lateral aspect of the acetabulum, which is an important prognostic sign that we will speak about slightly later. The bottom right picture shows a fully healed hip, and the current shape of the hip, as you can see, is different. The femoral head became mushroom shaped instead of spherical. There is some slight uncoverage of the femoral head because the femoral head became larger than normal, or what we call coxa magna. Also, the femoral neck is short, what we call coxa breva, and also we have a high greater trochanter, higher than the femoral head. Again, all of these changes are caused by the avascular necrosis. This X-ray shows few signs of late Perthes disease, or late X-ray findings of Perthes disease. You can see the coxa magna, which is an enlarged femoral head with slightly uncovered femoral head. Also, the femoral head is mushroom shaped with some fragmentation in the joint surface. There is also what we call the sagging rope sign, which is pointed by the 3 black arrows, and this indicates that the shape of the femoral head has changed from a sphere to mushroom shaped. Also, the greater trochanter is high, which what we call overriding greater trochanter. All of these are caused by the avascular necrosis secondary to Perthes disease. Other investigations are usually not required for Perthes disease, and the X-ray on its own is diagnostic. However, these investigations can be done sometimes to confirm the diagnosis and to plan treatment. Particularly arthrography, number 3 on the slide, which means injecting a dye inside the hip joint and then examination of the hip joint under X-ray control and under anesthesia can be helpful in planning the treatment. This is Herring classification, or what we call the lateral pillar classification. You do not need to know the details of the classification, but it is a prognostic classification and can guide the treatment. This is again the Herring classification in pictures. There are a few signs that indicates poor prognosis, what we call the head at risk signs by Catterall. There are clinical signs and radiological signs. These are the clinical signs indicating head at risk and poor prognostic, and this can guide the surgeon towards surgical treatment instead of conservative treatment. These are the radiological head at risk signs. Most importantly is the lateral migration of the femoral head, or the extrusion, as shown by the red arrow, which means that part of the femoral head is not covered by the acetabulum. Also, there are other radiological head at risk signs like the metaphyseal reaction and cysts, and the lateral calcifications and the gauge sign, as shown in the upper right picture. This is the gauge sign, which is a poor prognostic sign showing rarefaction of the lateral aspect of the femoral head, sometimes with a V-shaped bony fragment. Treatment of Perthes disease is usually conservative, and surgical treatment is rarely required. Generally, this depends on the classification and on the prognostic signs. Children that can need surgery are generally older age group, and the ones with the higher Herring classification, and the ones with head at risk signs, whether they are clinical signs or radiological signs. But again, most cases are managed conservatively without surgery. The goal of conservative treatment is to maintain the range of movements of the hip joint in order to avoid complications. If the range of movement is good, generally the problems are avoided. To achieve this, some children may require physiotherapy and some painkillers occasionally. However, as we said earlier, few patients require surgical treatment, and if this is required, we perform what we call containment surgery. So the prognosis of Perthes disease is generally good. Male patients who are young in age, who are the majority of cases of Perthes disease, they go back to normal or near normal, both clinically and radiologically. So the femoral head goes back to the original shape, and their range of movements is usually restored back to normal, and they can go back to their normal activities, including sports. However, there are possible complications that can happen mainly in patients with poor prognosis or poor prognostic signs. For example, females have worse prognosis. Patients who get the Perthes disease at an older age, especially if they are older than 8 years of age, and those who have head at risk signs, these can develop complications. The complications can either be in the form of premature growth arrest. Number one, it says physical arrest, but in fact, this should be physeal arrest of the physes, injuries to the labrum, osteochondritis dissecans, which is fragmentation of the femoral head with intra-articular fragments, and late osteoarthritis. All of these possible complications are caused initially by the avascular necrosis and by its sequelae, which can change the shape of the femoral head from a sphere to a mushroom-shaped. And this can affect the gait as well as it can cause permanent pain in the hip joint. These patients who develop complications will usually require surgical treatment in the future in the form of total hip replacement surgery. Our next topic is slipped capital femoral epiphysis, which is a less common condition that affect the adolescence age group. It is less common, but is in fact more important as this is an urgent case that requires urgent attention and admission to the hospital and is always managed surgically. This is a condition of the growth plate in the proximal femur. Therefore, you all need to know the anatomical details of the growth plate and you need to know the zones of the growth plate as shown in this figure. So basically what happens with this condition is a separation between the epiphysis or what we call the femoral head and the rest of the femur through the growth plate. So it is called slipped capital femoral epiphysis, which indicates that the epiphysis has slipped, but in fact the epiphysis is contained within the acetabulum and cannot slip. So what in fact happens is that the rest of the femur slips and the femoral head stays in its place. But it doesn't matter which part slipped. The most important part that it is a separation between the femoral head and the rest of the femur through the growth plate. This condition is more common in males than females, and it generally speaking affects the adolescent age groups between the ages of 11 to 15 or 16. 80% of cases are unilateral, but a child that develops a slip on one side is at risk of having it on the other side. So be aware of that. Also, children or adolescents with obesity or high body mass index are at higher risk. Patients with hormonal abnormalities, hypogonadism, or excessively thin and tall males are at risk. So many cases with slipped capital femoral epiphysis are idiopathic. However, there are few risk factors that can increase the risk of this condition. As we said earlier, obesity is the most important risk factors, and also endocrine abnormalities. Most commonly, hypothyroidism can cause that, and also parathyroid gland abnormalities, growth hormone abnormalities, and hypogonadism. Particularly, you will need to think about these endocrine conditions when the age range is slightly unexpected. Like, for example, very young children, less than 9 years of age, or older children, more than 16 or 17. Then in this case, you will need to look into that. Also, patients with bilateral slips, you will need to consider this possibility, and in female patients. Other risk factors include systematic diseases like rheumatoid conditions, vitamin D deficiency, etc. Clinically, the patient usually presents with pain, and the pain can be, as we said earlier, in the hip, thigh, or knee. Be aware of adolescent patients with knee pain, and always examine the hip. Because if you miss a slipped capital femoral epiphysis, this has significant consequences, and this can affect the joint adversely. As we said earlier, this is an urgent case that needs urgent treatment. Also, these patients can present with limping and abnormal gait. They can have antalgic gait due to pain. As we said earlier, antalgic gait means painful gait due to short stance phase during the gait cycle. Also, very often these patients have an externally rotated gait as the femoral neck slips into external rotation, which leaves the child with an out-towing gait, which means that the affected limb is externally rotated during walking. On supine examination, usually they have pain on hip range of movements, and they have an obligatory external rotation sign as shown in the pictures here, which means if you ask the patient to flex the hip, it goes into external rotation on its own. And this can also cause leg length discrepancy with shortening on the affected side sometimes. So the most important diagnostic test here is the X-ray. Again, we get two views, the AP view, which is shown on this slide, and most importantly, the frog lateral view, which shows the slipped capital femoral epiphysis, even if it is mild. On the X-ray, the things that we look for are as follows: widening of the growth plate, irregularity of the growth plate, reduction in the epiphysis height, and evidence of slip, which is evident on the left hip on this X-ray. You can see that the epiphysis is slipped in relation to the femoral neck. Number 3 is the Klein line, which we'll see in the next slide. This is a Klein line, which is used to diagnose slipped capital femoral epiphysis. Basically, this is a line that we draw on the superior aspect of the femoral neck, as shown in the figure A, and this line should always cross the epiphysis, and that's considered normal. If the Klein line is not going through the epiphysis, as shown in grade B, then this can indicate the slip. In this case, you will need to be guided by the clinical picture and look at the frog lateral view, and this usually can confirm the diagnosis. If you still cannot confirm the diagnosis, then you will need further imaging like a CT scan or MRI scan. Another sign is what we call the Blanche sign. Unfortunately, is not very clear on this X-ray. but basically it means increased sclerosis in the metaphyseal area caused by slippage of the femoral head posteriorly. So it overlaps the femoral neck from the posterior aspect, causing the appearance of sclerosis. Loader classification differentiates between what we call a stable slip and an unstable slip. And basically it depends on the ability of weight bearing. So the child who can weight bear, whether he can weight bear with or without crutches, this is considered a stable slip. If the patient cannot weight bear at all, with or without crutches, then this is an unstable slip. The importance of differentiating stable from unstable slips is the risk of avascular necrosis. So basically stable slips, generally speaking, do not cause avascular necrosis, and the rate of AVN is very, very low. On the other hand, unstable slips carry a very high risk of avascular necrosis. Up to 50% will have avascular necrosis. And when we say avascular necrosis, this is irreversible ischemia, not like Perthes disease that we discussed earlier. This is irreversible and it will cause long-term consequences, and the prognosis will be very bad. There are classifications to assess the degree of the slip and the severity of the slip. You don't need to know the details of these classifications. Now it is important to note that slipped capital femoral epiphysis is an orthopedic emergency because of the risk of avascular necrosis. Therefore, the patient will always needs to be admitted to the hospital and to be on complete bed rest without putting weight at all on the affected side. And then the treatment or the definitive treatment will be surgical, usually in the form of pinning of the growth plate to stabilize the slip, using a single screw as shown in these x-rays. For more severe cases, there are bigger operations to control the problem. But it is important to note that there is no role for conservative treatment in this condition. One thing to note that if a patient presents with unilateral slip, after stabilizing the slip surgically, you will need to observe very closely for the other side, because contralateral slip can also happen, and you will need to warn the patient and the parents to be very aware of this possibility and to seek medical advice if needed. The complications of these conditions are associated with the severity of the slip and with the stability of the slip. Unstable slips carry higher risk of complications. Also, severe slips carry more risk for complications, obviously. The main risk is avascular necrosis, or what we call osteonecrosis, which, if happens, it can have severe consequences for the patient, and they can require a total hip replacement in the future. Also, patients with slip are at higher risk of developing osteoarthritis and are at higher risk of requiring surgery in the future. Leg length discrepancy is also a possible complication, and also rotational abnormalities, usually causing out-towing of the affected side, which means an externally rotated posture of the limb during gait. Another risk or possible complication is chondrolysis, which means destruction of the articular cartilage of the femoral head, and usually this is secondary to the surgical treatment. if the pin penetrates the articular cartilage by mistake, then this can happen, and this leads to a rapid deterioration of the joint and early arthritis. So if you have any questions, or if you need explanations about any of the topics that we discussed, Perthes disease and slipped capital femoral epiphysis, we can discuss these questions in the clinical sessions. The rest of this PowerPoint presentation discusses Coxa vara, which is self-reading for you.